Good afternoon, everyone. My name is Jerry Bloomfield, and thank you all for joining us this afternoon for this Think Global session. We have a live audience here in Trent Hall, as well as a number of participants online. Just a few logistics just to mention before we get started. Today's session will be recorded and it will be posted publicly. We will have time for Q&A after the panelist presentations. In the room, when it's time for Q&A, just raise your hand and we'll get some questions in. For those of us who are joining online, please feel free to put your questions in the chat at any time. I will get to as many of those online questions as we have time for. Acute cardiac conditions, such as heart attack, are becoming more and more prevalent in low and middle income countries. Many hospitals lack the infrastructure, either in terms of equipment or trained personnel, to provide standard top quality care for patients with these conditions. This Think Global panel will explore addressing acute cardiac care conditions in 3 settings, Tanzania, Kenya, and Pakistan, and that will address how to improve capacity for these conditions, including long-range investments in training for physicians, nurses, and technicians. I'm now delighted to introduce today's panelists. I'm going to give extremely brief introductions so that we leave optimal time for the discussion, but please do take a look at their full biographies on the webinar website. We're going to start with Dr. Julian Hertz, sitting here to my left, who is an associate professor of emergency medicine and global health. Dr. Hertz's research focuses on using implementation science methods to address cardiovascular care in Tanzania. After Dr. Hertz, we will have a remote presentation from Dr. Farhala Baloch, who is an assistant professor of cardiology and an NIH Fogarty Fellow at the Aga Khan University Hospital in Karachi, Pakistan. Dr. Baloch's clinical and research work focuses on implementing and measuring patient-reported outcomes, amongst other interests. And then our final presenter before the moderated session will be Dr. Felix Barasa, who is a cardiologist who works at the Moi Teaching and Referral Hospital in Eldoret, Kenya. Dr. Barasa, his work focuses on addressing heart failure and cardiomyopathies in many sub-Saharan Africa settings. I should also note that Dr. Barasa is joining here in person as our annual Global Cardiovascular Health Visiting Professor. He's made a long trip from Kenya. He's here this week, supported by DGHI as well as the Division of Cardiology at Duke, with support from the American Heart Association as well. So with that, I will now turn it over to our panelists, and we'll start with Julian.
Thanks so much. I want to first acknowledge my primary collaborators in Tanzania, Dr. Sakita and Dr. Mbaga, who could not join us today, but obviously none of this work would have been possible without their leadership and vision. So as Jerry mentioned, myocardial infarction, which is commonly known as a heart attack, for those of you who are not physicians, is the leading cause of death and disability worldwide. And this seems to be true everywhere in the world, except possibly sub-Saharan Africa, which is a little bit of an epidemiologic curiosity. Obviously, historically, there's been a really large burden of communicable diseases like malaria and HIV. But as those of you who work in Africa know, there's been quite a large epidemiologic shift in sub-Saharan Africa, with a large growing burden of cardiovascular risk factors like hypertension, diabetes, obesity. But despite this widespread recognition of this epidemiologic shift, there's really been very little research attention or policy attention paid to heart attacks or myocardial infarction, which I'm going to refer to as MI for the rest of these brief slides. When we started this work back in 2017, one of the first things we wanted to understand is what is currently happening. Why is it the case that there's so few cases of MI diagnosed in places like Tanzania? And so we started working in the emergency department, and we just tried to look at what's happening to people presenting to the emergency department with chest pain and shortness of breath, which are the 2 most common symptoms of a heart attack. And we actually found that there was a very large number of patients presenting, and these patients had kind of classic cardiovascular risk factors, but very few of them got tested for a heart attack. And so one of the key ways you test for heart attacks with a blood test called a cardiac biomarker. And only 3% of these patients that by American standards we consider to be high risk were getting tested for that. And unsurprisingly, with this low rate of testing, there was a very low rate of diagnosis. So only about less than 2% of people presenting with chest pain were diagnosed. So sorry about this small slide, but this just summarizes the way we found that people with chest pain flowed to the emergency department. The figures that are gray are high risk by virtue of their comorbidities. And as you can see, about half of patients received no testing whatsoever. About half of patients received an EKG only, and a lucky 9 patients who weren't particularly high risk received both an EKG and cardiac biomarker, and half of those were diagnosed with an MI. So this raised the question that maybe part of the reason we're not reporting lots of MI cases, we're not testing for a lot of MI cases. So we followed this up with another study where we did essentially the exact same thing. We had the same inclusion criteria, and we tested everyone who presented to the emergency department with an EKG and cardiac biomarker testing. And we found an astounding number. And so 22% of the people that we found that presented with chest pain to the emergency department actually had a heart attack, which is a really shocking number in the US. Just for context, about 5% of people who present to the emergency department chest pain ultimately are found to have a heart attack. And so this suggests to us there might be actually quite a large burden of under-recognized MI in places like Tanzania. And it also suggested to us that maybe the kinds of people who finally make it to the emergency department in Tanzania are much more likely to have an MI than patients in the United States, for example. And unfortunately, we followed all of our patients out for 30 days, and we found that 43% of patients with an MI die within 30 days. This is the highest mortality, 30-day mortality rate that's ever been reported for MI anywhere in the world. So this was a really concerning result. These two figures just kind of compare what the rates of MI diagnosis were with routine care in 2018 and when we started testing everyone in 2019. And basically comparing these two pie charts, about 90% of MI cases we estimated were being missed by routine care. In addition to low rates of diagnosis, we also found low rates of treatment. And so one of the key components of acute MI treatment is aspirin, believe it or not. It's reduces both morbidity and mortality in acute MI. It's cheap and widely available in a place like Tanzania. And we found that only 23% of patients who had proven MI were receiving this therapy, and lower numbers were receiving other elements of evidence-based therapy. This graph emphasizes what I pointed out already, which is that the mortality rate we found in Tanzania was really, really exceptionally high relative to what's been reported anywhere else in the world. We followed our patients out actually for a year, and we found, unfortunately, the mortality rate of our patients continued to climb up to about 60% at 1 year, which again is in far excess of what's been reported elsewhere in the world. In addition to many of these patients dying, or the majority of these patients dying, we found that overall those who were surviving were not doing well. So the vast majority of them still had daily chest pain. Less than 10% of them, only 5 patients were taking any kind of aspirin or antiplatelet, which is indicated for prevention of future cardiovascular events. And we were really focused on aspirin in particular because aspirin is actually a WHO best buy for reducing non-communicable morbidity mortality. So aspirin is just so cheap and so effective that the WHO says one of the best ways you can reduce death and disability from non-communicable disease is give every patient who is having an active heart attack or who has had a heart attack aspirin or some other antiplatelet agent. And because of this, we really focused on trying to find a way to improve this specific number. And this kind of problem is a problem for implementation science. And as you all know, implementation science is how do we get the thing that we know works, that's been proven in multiple trials, to actually reach patients, especially when it's a new context with particular resource restraints or unique contextual factors to consider. So we spent about a year working with our colleagues in Tanzania, and we used a co-design process, essentially where the intended end user, which is the ED physician and the ED nurse, were part of the design of the intervention from the very beginning. And we needed an intervention that was low cost, that was sustainable, that was feasible in this context. And the intervention we built was called Mimic. Briefly, it's a 5-component intervention. It includes some special reminder cards that the physician gets, the triage nurse places on the stretcher to remind the physician to consider the diagnosis of MI, pocket cards, a training module, dedicated champions, and patient education pamphlets. Very briefly, and I apologize for the small text again, we piloted this intervention for a year and we found that it was actually enormously effective. So in all of the outcomes we looked at, whether the patients were getting tested or whether the patients were getting evidence-based treatment, we saw extremely large effect sizes with the post-intervention patients in the light blue and the pre-intervention patients in the dark blue. We even saw downstream effects that we weren't expecting, such as 30 days after hospital presentation, this ED-based intervention seemed to result in about a 5-fold increase in the number of patients taking aspirin, which is rather surprising for an ED-based intervention. So we're doing lots of ongoing work right now. Just briefly, after we concluded our trial, a main challenge, I think, in a lot of implementation science work is you get these researchers come in, they build something, they implement it, and then they leave and it falls apart. It's very, unfortunately, almost the rule rather than the exception. And so one thing we're really focused on is trying to figure out, is this actually going to stay once the research team leaves? And so we ended the study over a year ago, but we've been secretly monitoring for the past 18 months. And we found actually that uptake of the intervention and performance has actually continued to improve, which is not what we were expecting. So we're very pleased about that. We're using some kind of novel instruments to look at normalization and sustainability. There's the CSAT and the NOMAD surveys that I can talk about later. And we're in this early stages of planning for multi-site trial to try to build this out to other sites across Tanzania. So these are our brief conclusions. In Tanzania, MI is much more common than previously recognized. There are substantial opportunities to improve MI care in Tanzania, and the MIMIC intervention is low cost and effective in terms of improving MI detection and treatment in Tanzania. I'll stop there and pass it on to my colleague. Thank you.
Great. Thank you. I'll pass it on to Farhala. Welcome from Pakistan, Farhala.
Good afternoon, Dr. Zairi. Thank you so much. Can I start sharing my screen?
Yes.
Yeah, thank you. So just let me know if my screen is visible to all of you.
Yes.
Okay, so thank you. So without taking more time, I'll start. I'm from Pakistan, and for all the audience listening to me online and on site, Pakistan is a developing country in the South Asian region. It's a lower middle income country from the South Asia. As Dr. Jerry already mentioned, I am a Fogati Fellow, NIH, and assistant professor in consultant cardiology. So I have no industrial disclosure other than that I'm a Fogati Fellow. So South Asian is basically, the CVD is basically emerging as an epidemic in the South Asia. And we are estimating the prevalence of CVD will actually get double in the 2 decades. STEMI is not uncommon, and it's almost responsible for 25 to 40% of all MI cases which are brought to the emergency room with a chest pain, with a STEMI mortality up to 9.6% in developing countries. We all know here, the people we are sitting in the room, that various quality parameters are identified and taken care, and they are benchmarked during the process of the care which is provided to the acute MI patient. And it is usually governed by the ACC registry, which is National Cardiovascular Data Registry. The purpose is to deliver the best and defect-free care to the acute MI patient. But yet in developing countries, like if I take Pakistan as a use case, till 2017, there was no national registry for the acute MI care or any data visualization system. And the main purpose behind this is the decentralized healthcare system, because we have 4 provinces across the Pakistan, and each province is autonomous to take care of its own healthcare system. All public and most private hospitals do not have an electronic acute MI data dashboards. So with this background, in my next slides, I'll present some work that we have initiated at our institute level and then at the national level, which we are also participating in that, to actually improve the data visualization and the data centralization system in the developing country like Pakistan. So this was so after identifying these gaps in 2017, after some piloting and negotiation with the with the hefty funds actually that is being charged for these international registries for the international participants, we were able to participate in the National Cardiovascular Data Registry from Pakistan. From our center, we actually started submitting our data, and then in 2019 and 20, we actually analyzed our own data of a single center and publish it. So we found out that as a single tertiary care hospital, we had a 536 acute MI patient with a predominantly male gender. Diabetes and hypertension were the major risk factors for acute MI, with 14% STEMI and majority non-ST elevation MI. Almost 50% of STEMI patients got immediate PCI, but only 88.8% had the stent implanted. So with this data, and one of the only, along with us, only one of the other private institute was actually participating in the National Cardiovascular Data Registry on a regular basis, on the yearly basis. None of the other center from the Pakistan was actually able to not only to participate in the international registry, but even there was no concept of a national registry who can actually collect the local data at the national level and convert it into a meaningful patient's data. So with this approach, the National Society, which is Pakistan Society of Cardiology and Pakistan Society of Interventional Cardiology, come up with an idea after some events, kind of a sentinel event, I can say, happened with the care that are like very common throughout the world, and they were actually discussed with the law enforcement, and then they put the responsibility of developing a national level registry for acute MI patients on the shoulders of the people who are looking after these societies. So with this in 2018 or 19, we had this establishment of Pakistan Society of Interventional Cardiology, Cardiac Registry of Pakistan. So since 2018 and 19, this Cardiac Registry of Pakistan started inviting all the cath labs across the Pakistan to register their acute MI and all other cath procedure patients, especially the coronary procedure patients, even if they are elective and not acute MI, into their registry. This registry is being, there's a steering committee, and it has been run by the pioneers in the cardiology and the senior members of Pakistan Cardiac Society and Pakistan Society of Interventional Cardiology. And I'm sharing the recent report of this this registry, that is the year 2024. So across 210 cath labs across the Pakistan, we were able to actually register 190 cath labs, and my own institute's cath lab is one of that. If we look at a glance across the data from the Pakistan, because now my previous slides are representing the data from only one private sector institute. But this crop registry, after establishment of this crop registry across the Pakistan, we were able to gather the data across the Pakistan from all the 4 provinces, and to generate our local demographics and epidemiologies. So we can see, like in 2024, approximately whatever patients was reported, almost like 38,000 procedures were done. And out of that, almost like 40% were the PCI also. We can see in Pakistan, the predominantly acute MI patients are with the male predominance, with the age distribution from 41 to 70 years, covering the predominant presentation. You can see like this was the reflection from our single central study also, that we found diabetes and hypertension is a predominant risk factor for acute MI, and the data from all over the Pakistan reflected the same, that hypertension and diabetes were the topmost risk factors for the acute MI. Our Pakistan's median door to balloon time the last year was almost 101, and this was the discharge status, the kind of a mortality presentation. Overall, we can see that the STEMI had the highest mortality, followed by the non-ST, and then some non-SES patients that were also the part of this registry. So after this, when the registry was established and the registry stakeholders were able to enroll almost more than 95% of the cath labs. Now the question was, there were challenges with these kind of registries in the third world countries especially. So now the question was, is there a better way of leveraging acute MI data in the country where the quality of the data is not being questioned, and we have the data which is equally measurable and benchmark as the international standards. So with this question, we from our institute, Dhaka University Hospital, lead by Professor Zainab Samad, actually plan a study which was published in the Global Heart Health in 2023, and background was to understand the temporal disease pattern of acute MI characteristics and outcomes between 1998 to 2018. So Dhaka University Hospital in Pakistan, as I mentioned in my first slide, that few of the public sector hospitals have the digital data or the electronic data, not in the form fully electronic health record form as in the US, but some digital data is there. We can say like part of the data is in the files and the part of the data is in the digital form. And so we thought that and because that data is ICD coded, so we thought that, and the data which is being entered in the registries by the in the international level registries, they are not ICD coded most of the time. So we thought, so let's thought about if we utilize this availability of digital data, and starting from our center, because in Pakistan our center has the right now the most I can say a better existing system of this digital health data. So the authors review the digital health information capture system maintained across the university and curated a master data set. All the patients indexed and their index admission from 18 years from January 1988 to December 2018. So you can say it's a 30 years data with a primary discharge diagnosis of acute MI, which was coded by our HIMSS department using ICD code 19. And the outcomes evaluated was in-hospital mortality. And very beautiful trends were actually seen by the single central center study. You can see the trends in the index acute MI admissions from 1988 to 2018. And then trends in the proportion of STEMI patients. You can see how beautifully the non-ST and ST segment elevation proportion of the admission has actually gone down from more STEMI admissions in previous years, and now less STEMI admissions in the recent year. Or we can say that more non-ST segment elevation patients are getting admissions and getting attentions. And which is a good thing also, because the mortality and morbidity of the non-ST elevation MI is also high in the developing countries. And we can see in the trends in the acute MI mortality over the decades, so the mortality has definitely gone down from like 13 to 9.2, but it is still like kind of more than 5 to 7%, which is mostly reported in the developed countries. So the authors concluded that the use of large electronic data to gain insight about the disease pattern is feasible in lower middle income countries in the acute MI patients, with acute MI patients. There are definitely strengths and challenges of these steps, and if this is feasible to gain an insight to acute MI trend in LMIC, and there are the opportunities for international registries exist, But the decentralized healthcare system in Pakistan make it very challenging, and we cannot like do it at a national level. We do it at an institute or at a provincial level. Then the national registries has been established, like I share the example of Pakistan cardiac registry, which is a crop, but the quality of the data and the equality of the data and the benchmark is very much challenging, and still the benchmark has not been set. And we are actually measuring our quality of the care by the international benchmarks. Then for the international benchmarks, of course, the cost of the participation is a challenge. And of course, there is no emergency medical services for the acute MI because of the decentralized care across the country. So in conclusion, so what we thought about like as a living as a use case in Pakistan, and especially in this province where the Afghan University is, we have started promoting public and private partnership. That the public hospital have a huge data, and the private hospitals have the data and the skills. The less data, the more skills, and the public hospitals have more data but the less skill. So we are actually partnering and mutually sharing these skills and the data so that we can for the common interest. And that's what we are promoting now from our platform. And when we hope that with a lot of collaborations with other government and public and private institutes, we will be able to actually make a central level dashboard that can visualize the acute MI data, just like happened in the COVID era all over the world. But for that, of course, a sustainable funding and infrastructure is the key to expand this concept. And so these are all the collaborators and research team of our ischemic heart disease projects, and we are working and heading with the mentors, Dr. Zainab Samad, who is a Duke alumni and currently a cardiologist and chair of our Department of Medicine, and my mentor also. And we hope that we are on the way of betterment, and we will be able to build a centralized data system to create our own benchmark and to improve the care of the acute MI patients in developing countries like Pakistan. Thank you so much. With this, I end my presentation.
We'll have good time for question and answers after our next presenter, Dr. Felix Barasa. Get your slides queued up, and then we'll go with you.
Thank you, Panel Chair, for the kind introduction. Thank you for having me. I feel deeply honored. Let me also take time to thank the esteemed audience, both in the room and online, for creating time to listen to us. So I've been asked to talk about a specific issue of cardiac care, and I've chosen to talk about training for the HR resource that is going to be part of the quality of care that is badly needed with this developing. Well, so I'll be talking specifically about the fellowship training program that we have at Moi Teacher Referral Hospital. And what we started with was a curriculum so that we can be able to develop or train much needed manpower to deliver quality care. We have a curriculum that is domiciled at Moi University, which is the medical school in the western part of the country. And the teaching facilities are provided for by the sister institution, which is now the referral and tertiary hospital called Moi Teacher Referral Hospital. We both occupy the same campus. And I should mention at this early stage that this is the only fellowship training program for cardiologists in the public space in the country. It's a 2-year program. It's competency-based. It's full-time. And we build our training on several foundations. Key among them is that partnership. And our key partner here is Duke University, together with some other local hospitals and institutions that help us in terms of attachment and mentorship for our students. The curriculum is built around the concept, the philosophy of problem-based learning, so that we encourage our trainees to be more thinkers and creating solutions for the problems that we face with our patients. We also have a strong mentorship program, both within the campus and from outside, engaging our partners so that they can also provide oversight mentorship to our fellows during the training period. From the very onset, we are writing this curriculum. I hope you should be able to read that despite the font. We were deliberate about what we wanted our graduates to do as part of the training. So number one, we wanted them to be astute clinicians, some diagnostics, decision making, and care about patients. We also wanted them to be teachers and for all levels of cadres, from nurses to medical students to the community. We also wanted to be creators of knowledge, and this was to be through research, and that is why the training program was a strong project in terms of research and deliverable. Then we wanted them also to be leaders, because at that level of training, one, the agenda are going to be local leaders so that they can be able to engage the wider community. And then finally, we wanted the graduates or the products to be advocates of cardiovascular health in the community. So to be able to deliver on this project, we were again deliberate on whom we wanted to be part of the training to be able to get that kind of product. So we take physicians. These are doctors who are filling their basic degrees in general medicine. They have also done a master's degree or a postgraduate degree in internal medicine. They have graduated. Then they have been out there or finished at least 2 years of practice post-graduation, which means that very serious doctors. And then they must have recognition from Kenyan Medical Board. And of key is that they must be outstanding character, professional integrity. And this is definitely acquired through a competitive recruitment process. So where are we in terms of this training program? We admitted the first batch of 2 fellows in 2019. We have been taking 2 for the purpose of having optimal contact with the faculty. So far, we onboarded the 5th cohort this year. The trainer at the moment said you only take 2 class group intake to make sure that there's optimal contact, be able to fit in the facilities that we have. 3 groups are finished. So we have graduated 6 cardiologists. And I'm proud to say that all of them is 100% have graduated and out there serving the community. And we have 4 others training at the moment as I speak. So what have been the impact so far for the short period we have been doing this? So 6 cardiologists graduated, another group that's graduating this year. Actually next month, but they're already out there serving the community. Of the 4 who are fully graduated, 2 have joined faculty, and this is again part of capacity building care, not just for patient care, but for capacity of faculty. One of them has joined a teaching hospital, and another is private practice. We have also had a very vibrant expanded cardiovascular service at MTRH. And then alongside that, we have a very, very busy inpatient unit, 14-bed CCU. We have a very busy non-invasive lab, which mainly deal with non-invasive diagnostic like cardiac, ECG, echo, and treadmill. We also developing space intervention. We have a very, very robust outpatient service clinics, see more than 8,000 patients. And then even the consult service is very, very vibrant, especially with the fellows who are moving from specialty to doing the much needed consult for the patient need cardiovascular consultation. Alongside those, we have other beneficiaries because the senior doctors, they also provide the oversight mentorship also to MA students who are doing postgraduate programs, including those who are doing undergraduate courses. I should mention here that we have a number of participants who may not be in the room, but who have contributed significantly to the growth of this program. Mentioned here is a gentleman called Dr. John Lawrence, who has been part of this program from the very inception, and after retirement has taken about 12, 15 years just making sure that this program takes off, and he has retired, but he's still part of the team, and he still continues to oversee what we are doing and provide guidance. So I think I can stop there. I think I can have made some basis for further engagement and discussions as we move forward. Thank you, Chair.
Thank you, everyone. I feel like we've heard about acute cardiac conditions really across the spectrum, right? From at the point when it's an emergency and it's life-threatening. Our last presentation touches on who is actually dealing with these patients, especially in LMIC settings. And we heard how we're using data and visualization to guide how we manage these acute conditions. So really across the breadth here. I'm going to start the moderated discussion and question session. If you do have any questions along the way, please feel free to raise your hand or drop them in the chat. But I'm going to start with a question to all participants, and we can just go in the order that you presented in to start. You know, as I think about the different contexts and countries, I think about the different phases of acute care that you're dealing with. I'm wondering, you know, and you've also described pretty impactful programs that's changing care and changing how we think about acute conditions. If you could think about one system enabler, you know, what's been one key ingredient to the success of the program that you're leading? How would you share us what one system enabler might look like?
Thanks. Yeah, I think of the three contexts discussed today, Tanzania is probably the most resource limited in terms of what's available at your typical hospital and even what kind of specialists are available. And for that reason, I think a key in systems, I don't know if that's the right term, enabler has been the co-design approach of our work, really letting the Tanzanian team drive intervention development and the whole process of implementation mapping, which is you identify the barrier and then how do you exactly map a strategy that's really going to overcome that barrier. And so I think one of the reasons our program has been successful is that it's been so feasible and so appropriately designed within the existing system. And so really all the credit goes to the Tanzanian team. The enthusiasm from the team for more training in MI care and to build something that they can be proud of and that they can own has really, I think, been the primary driver of the success that we've seen.
Arhala?
Yes, Dr. Chari, it's a very good question. I think because especially in the lower middle income countries or the developing country, system enablers and the challenges are the key implementation parameters that we measure. So for us, the most important system enablers was actually the huge data. We have the data, it's the infrastructure and the visualization or the contextualization of the data that was lacking in our country. So once we identified that gap, it was not the availability of the data. I can say it if I compare it with some food recipe. So the ingredients were all there. It was just we did not know how to cook it. So we started this initiative, and we are very much confident that starting from one institute and then at the other institutes and even at least starting a national level registry, because we have the data, so we will be able to actually create our own benchmarks, and in the near future, hopefully we will have our internal benchmarks that can actually guide us to improve the further care of acute MI patients. So I'll say it's a huge data that we have, and we just need to centralize it, and make it manageable and generate the evidence from that data. And that was not possible without the initiative of creating the registries and the dashboards.
Turning data into useful information.
Yeah.
Barasa, system enabler.
Thank you. Thank you for the question. I think a few things here I should mention. Number one, will be this strong partnership that we have with you. That encouragement to say you can do it. That encouragement to say wake up, try. That encouragement to say you are able to do that. And I should mention this particular jungle, this lady, the lady who had seen the Binane. The Binane was actually on our neck every day, and he used to say, let's move on, let's go get going. And she was actually like part of the whole team, despite the fact that she used to sit in this particular building. But this a lady that you are in communication every day and supported the program. Of course, alongside John Lawrence, as I mentioned, was a key person in this. Not to forget Jerry here was again part of the journey. Another enabler has been a systematic issue with the institutions we work with. Number one, with the Moi Teacher Referral Hospital leadership. I think they were deliberate about expanding training so that you can be able to offer level 6 or high level quality care and become centers of excellence. And again, the Moi University School of Medicine, the leadership, they are very, very key in terms of making sure that the curriculum is actually crafted, implemented, and monitored to make sure that we achieve the desired. Lastly, I should say, team spirit. I have a very strong team on the ground, and we all have one thing: they desire to succeed. That has created and propelled us to be where we are today.
Okay, great, excellent. Farhala, a question for you. You talked about the registry and your visualization approach, and how there seems to be a wall or a disconnect between what's happening at one institution versus nationally. How do we, or how would you, what would you change to expand the utility of the registry that you're currently working with to actually make that more useful in, the 200 cath labs that there are around the country? How do we get everyone thinking about benchmarks and visualization?
Yeah, it's a very good question, Dr. Reddy. And it's actually your question is actually the main challenge right now that we are facing at the cardiac registry of Pakistan level. It's about the quality of the data and the lack of uniform training that all the cath labs or the data providers are lacking. So only 2 institutes from Pakistan are providing data to the National Cardiovascular Data Registry, and they are like very much aware of how the cardiovascular registries work, and what are the modelings techniques, and what are these different performance and quality and the outcome metrics. The rest of, I can say, like out of 210, the 208 cath lab don't even know about these things. So in my opinion, if I would have be doing something better in terms of these registries and everything, it's the training, providing the training on these acute MI related quality of care metrics, because the merely just collecting the data and just dumping it into a registry will also be will be of no use, and will not be able to generate the evidence which can be used then improve the care of the patients. So in my opinion, the uniform training at the national level, maybe in collaboration with the international partners like the ACC or the NCDR, will be a great help for developing countries like Pakistan, so that they can build their own registries, which are equally validated and reliable like the international registries are. And we can actually proudly present our data at the international forums that the quality of the data is robust, and the rigor of the data is actually challengeable. So in my opinion, I think it's very important that we should have a collaboration with the well-settled international registries for the Pakistan and other developing countries of the South Asia to get a uniform training so that our registries are better representation of what actually the data is.
Yeah, great. And I think about, things like the World Health Organization STEPS survey approach. I mean, there's definitely a platform to speak to many stakeholders at once. Julian, a question for you. I really liked the slide where you showed where implementation science fits into, bridging the gap between what we know and what we do. At the same time, you described your setting as one of the more resource limited settings that we're talking about today. So how do you balance good science like implementation science with realities like, staff turnover, USAID funding no longer supporting parts of the mission, limited diagnostics, competing priorities? How do you balance some of that research in the real world and in implementation science in your approach?
Great question, as always. I actually think that's actually what makes good implementation science is when you're actually working in a challenging environment. Because if the environment isn't challenging, you might not really need as much implementation science. And so I think thoughtful implementation science is all about contextual factors. And so for us, like every element of addressing the problem needs to address contextual challenges, such as in Tanzania, there's not really much training in myocardial infarction care as part of standard medical training. And so, you have to really do good qualitative work, I think, sometimes to really understand the barriers. And only in qualitative work were we able to get doctors to tell us, I don't know how to read an EKG. I was never taught. That's the kind of thing that you're not going to get from quantitative data easily. And so understanding exactly where the knowledge gaps were, for example, for physicians, allowed us to build an intervention that had a low time commitment module that exactly addressed the key gaps that were affecting care. And we also had to do it like a Google form that actually a DGHI master student built because we need something cheap, open access that would work and be sustainable in the environment. And so every step, I think, of thoughtful implementation science is all about what specific resources are available. Because if you build something that's not sustainable or feasible, it may make a really nice pilot study, but then won't actually have any kind of long-term impact.
Excellent. Great. Well said. Barasa, as you were describing the trainees in the curriculum program, you kept saying something, and I hope the audience caught it. You kept saying, serving the community, cardiologists being trained and getting back out to serving the people who actually need this advanced cardiac care. So how have you thought about in your program at Moy, how have you thought about bridging that gap between training in the big institution, the big referral hospital, but actually meeting people in the community who have, these risk factors for acute care? How have you thought about that?
Thank you. I think that was a key component of when we were designing this curriculum, because we realized that more than 3/4 of the cardiologists in Kenya are actually at the capital, that's Nairobi. So only about maybe 15% of the cardiology in the country are outside the capital. And I think that is for obvious reasons. But when we designed this curriculum, initially we thought, because of building rapid capacity for faculty and for the hospital, we actually thought that maybe the first 2-3 classes should just be limited to physicians within the hospital. But as time went by, we opened up to competition. And the reason was Kenya is a vast country with a lot of inequalities. And we were actually thinking that if we can get maybe for every 200 kilometers or 100 kilometers, there's at least a cardiologist, we are giving priority to such a person, because when they go back, they're going to make a huge difference. Because many of these patients, leave alone physicians, they may not see even a medical officer. But if they can be able to be caught at and maybe be rheumatic disease, early there is a disease process, be it an ischemic event, heart disease, then they can be picked up, and by the time they're being referred to these big centers, it is fairly early, then they can make a different amount of their care. So luckily, we have been able to get these physicians. We have attracted one from Western Kenya who has said now teaching one of the universities. There's another from the northern eastern part of the country now in training at the moment. And then there's another from the eastern part of the region. It just worked out by luck that they were actually attracted this program. And I've gone back, and I'm sure they'll make a huge difference in terms of early diagnosis and early referral for those who may need maybe further evaluation or intervention. And I'm sure it's going to make a huge difference in the care of these patients.
Let me just touch base with our online moderator to see if there are any questions we think about online or any questions in the room.
There is one online that was directed at Dr. Boj, and she actually answered, but maybe she can say her answer also out loud so the in-room audience can hear.
Would you mind repeating the question briefly, Farhalan, and your answer for those in the room?
Yes, I just type in. So the question was on the cross training, because I talk about the more training regarding the registries and all these things. So the question asked was that what are the roles and responsibilities? Are they divided between the partners? So my answer was like this cross training. Yes, the cross training is happening, but this is only for those participating cath labs who are actually participating, and it's a paid participation. Luckily, like we have we somehow get some negotiation because on the current rates, but those cross training opportunities, like for example, the NCDR training on the how to develop a registry for the acute AMI and how to maintain it, and then how to improve it on like a regular basis. It's only for those cath labs which are actually actively participating. So as I mentioned, currently from the Pakistan, there are only two centers, and they are actually public sector centers which are regularly submitting the data and getting their outcomes reports from the NCDR, and then they are actually being given the silver and the golden and the platinum achievements awards also if they are like fulfilling the criteria. None of the other cath labs have such a strong concept of this performance measures and quality metrics and the outcome metrics. So I think these cross training should be as an in-kind training, should not be for only those centers who are actually providing you the data. That should be open for everyone, and especially for the lower middle income countries that make actually a basis for them to develop their registries to international standard. So that was the question.
Excellent, excellent. Thank you. Thank you. Well, let me ask one final closing question here for all of the panelists. We're going to try to end on a positive note. An even more positive note than we have been. As you look ahead, 5 to 10 years from now, what gives you the most optimism about improving cardiac care in the places where you work? What gives you the most optimism about what the future looks like? And we'll take this in reverse order. We'll start with Dr. Barasa. We'll go to Dr. Beloshin and Dr. Hertz. What gives you the most optimism looking 5 to 10 years from now?
Thank you, Chair. I'm very, very optimistic as I sit here. And I'm sure that we are going to succeed. So far, my experience that the Duke has taught me a lot of lessons to carry home, which we should be able to implement a few based on the resources we have. So I have a strong team on the ground, young faculty, a lot of support. And so far, even the interest in the program, based on the kind of the patients we have, coming for care, the students we have applying for the program is all optimistic. And as I said, with the young faculty we have at the ground, the future can only be bright. Thank you.
Yeah.
Oh.
So, Dr. Jerry, can you repeat your question? The optimism?
Yeah, if you look forward 5 to 10 years from now, what gives you the most optimism about improving care for acute conditions in Pakistan?
I think the most important point is, as I already mentioned, that we have the data and we are gradually towards betterment. And we have identified our challenges, and these challenges are basically decentralized system. With these initiatives, we are providing evidence to the government of Pakistan that a centralized acute MI care system will definitely improve the outcome of these patients. These examples are like the initiation of this national level registry, and then most of the hospitals are now actually working on not wasting the data in the or dumping in the files, and then they are actually converting their data resources so that they can utilize and generate their own evidence. So I think the most optimism is identifying our own gaps and challenges, and we have started working on them, and very much hopeful for the next 5 to 10 years. We in the Pakistan will have a better system of data, our own data-driven care for the acute MI patients, with the definitely continuous support from our international collaborators.
Great. Again, just to note, it's very late in Pakistan, so we appreciate you being online.
Yeah.
Someone can look up the time change. We appreciate you.
Perfectly fine. Yeah.
Yeah, I have three things that give me optimism. First, I think is the sustainability that we've seen of our intervention and the improved uptake of both the continued improved performance even after conclusion of the study, which has been really rewarding to see. The second is the kind of broad spread enthusiasm that we've seen and sort of planning for next steps and meeting with heads of hospitals all across Tanzania, just uniform extreme enthusiasm for the project, wanting to be engaged, wanting to bring this sort of work to their hospital. And then finally, attention from the Ministry of Health. 10 years ago, you couldn't find a paper about myocardial infarction in Tanzania. And when we started doing this work, there was one cath lab for a country of 70 million. And now there are 3, and they're building a 4th at KCMC, the hospital we've been working at. So that gives me great, great optimism for the system and for the patients.
Yeah, great. That's wonderful. I mean, as I reflect as we bring this session to a close, it reminds me that there certainly is an important place for acute care for acute conditions in the global health space. And a lot of the building blocks for that are building blocks that we see across, the health system strengthening landscape. We've heard, partnerships, international partnerships. We've heard the role of students. There are a lot of students in the room right now. Of course, resources, engagement with the ministry. I love the fact of sort of co-designing, and then using data to drive home your point, all with the idea that, the people that we're trying to reach aren't necessarily the people who live and work in our RV towers, but they're in communities that we want to engage with. So I'm finishing this session, leaving this session really encouraged and optimistic myself about hearing more of the good work from these 3 contexts. I want to thank all the participants and all the attendees for joining today.
Thank you, Dr. Jerry.
Brief reminder that there will be a recording available on the DGHI YouTube channel by the end of the week. And with that, this session is adjourned. Thank you, Farhala.
Welcome. Hope to see you in Pakistan soon.
See you soon. Yes, that's the plan.